Hi everyone, welcome to the next episode for the podcast. So today we are joined by Dr. Sujit Chatterjee. We are here in Adi Arogya Hospital in Vikroli, and the topic for today is what the pain points are in a hospital and in the healthcare sector. Before we begin, a brief introduction for Dr. Chatterjee. So, Dr. Chatterjee's area of specialization is in obstetrics and gynecology, and especially in gynec oncology. So, sir also before this worked as CEO for Dr. Hiranandani Hospitals for about 22 years. Before that, he was a professor at the of obstetrics and gynecology in Mumbai University since 1991. He was selected by the armed forces for super specialization in gynecal oncology and trained students specially in preventive measures for oncology and all related surgical techniques and chemotherapy. He's very well known for sharing his views, and we are excited to be joined by him over here. Uh, so Adi Arogya is a women's hospital, the Women and Infant Center, and it's a 110 bed obstetrics gynecology center with a very strong focus on high risk pregnancy, neonatal intensive care, and infertility. And we would like sir to maybe speak a few words about the hospital.
Let me start with the element of correction. We are a 140 bedded super specialty hospital, and we have every modality of therapy, right from obstetrics and gynecology to cardiology to neurology, neurosurgery, the works, and we have an infrastructure to back that up. And at the same time, the hospital is poised to expand vertically because we have enough and more FSI. And also, there are plans for further expansion, which would ensure that the hospital becomes not only a tertiary care center, but a quaternary care center, where we'll do various forms of transplants and including radiation oncology and the works. So, therefore, this hospital is going to be, in a short point in time, the leading hospital not only in this local and regional area, but possibly in the city of Mumbai, God willing.
Oh, great to hear. Yes.
So, how this hospital is different from other mother and child care? What is the niche kind of you can glorify?
Shantanu, we are not a mother and child hospital. We are focused on the fact that we are a multi-speciality tertiary care hospital.
Okay.
But if you talk in terms of niche areas, then right now, at this particular point in time, we are focused on the fact of metabolic medicine.
Right.
Metabolic medicine is going to be a scourge, and it's a scourge for many decades going forward. Because, like COVID, which was an overt pandemic, this metabolic syndrome is a covert pandemic. And Mumbai is facing the brunt of it, but nobody will really want to admit it. So we have set up in a small manner a metabolic center where we advise you holistically. It's not all about diabetes, but it's all about your glycerides, it's all about your weight management, how you eat, what is your lifestyle, everything. So that put together, and when we expand, we will expand this initiative much further and have a full team of people who will be looking after and addressing metabolic medicine.
Okay. And sir, as I understand, this is a multi-speciality kind of kind of. It will, I mean, when you go up the vertical, will it be a quaternary care hospital also?
Yes, it will be a quaternary care hospital. As I said, that it's not only the vertical part, but it's also going to be expansion on land which we've recently acquired, and we will build on that also. And so we have very ambitious plans to grow from at least 140 beds to 350 odd beds. Anything more than 300 would suit us, and we will have to align our specialities to ensure that the 300 beds get occupied.
Okay. Okay. How young is this hospital, sir?
Well, the infrastructure is as old as 2014. That's maybe we are running our 11th year.
Okay.
But as far as our group management is concerned, we are just about 4 months old. This is an initiative of a company which is called Seaview Management Services Private Limited, for which I am the CEO.
Okay. Okay. And sir, what was the kind of the difficult part in putting up the hospital setup in last say 1 year, since the time or kind of you have been kind of joining the organization?
Since the time that I have been associated, the infrastructure was not addressed. The maintenance of the infrastructure was not good. Being a brownfield project, we had enormous issues with the air conditioning system, the HVAC system, including the electrical systems, and a lot of firefighting equipment, and including the alarm sensors. There was a total mismatch. That means if a sensor number 23 was located at ground floor and you found sensor number 23 beeping, you found that it was beeping from the third floor. So while the alarm showed ground, actuality was 3. Okay. So we had to get all of that in line, because the fire NOC these days is very, very, very strict, including the sprinklers. The fire officer will come and light a fire. He'll actually light a fire to see the sprinkler explode and see the radius with which it spreads the water.
Okay, okay.
So this is actually a question that I have been very interested in since my time in HOSMAC. What do you think about this idea where a hospital can be doctor driven or brand driven? Where sometimes it's the doctor who is the face of the hospital, versus sometimes it can be a multinational corporation which is the face of the hospital. What is your take on this, and anything?
It pans out equally, because any hospital which has got a brand, which has built up a brand, will certainly have certain amount of doctors who are very well known in their field. It happened with the great Dr. Pratap Reddy. He had Dr. C.S.V. Subramaniam, who is the lead pathologist. He had Dr. Arkut and Dr. Giriraj, who were the cardiologists and nephrologists. And at one particular point in time, each and every one of them had an independent reputation, but they were associated with the organization. So therefore, it can happen that you have a lot of doctors, and those doctors are extremely well known in their profession. So at that vertical, they may be higher than the brand value. So the doctor's value in that only one vertical might get higher than the brand value. Yes, there is that issue.
Okay.
So there is always a pro and con. It may be a kind of doctor-driven or a brand-driven hospital. Suppose a doctor-driven hospital, but if some entity is famous for a particular surgeon or a doctor, suppose he is not there tomorrow, he malfunctions, and he is not able to develop his associate people. He may have lots of assistant, but he may not have an assistant surgeon. Then will it be a jeopardy for losing the brand name as well as the doctor's name, and the entire facility doesn't function, or it doesn't attract the maximum footfall?
See, let me be very clear on this, is that if the hospital is known for the quality of care, then I think whether this brand of a doctor is present or not present will not make too much of a difference. But it has to be an overall quality. See, you cannot have, say, in one discipline, fantastic quality, and the rest of the disciplines, very average quality. That is where you will face a difficulty. But if the facility overall has a particular quality which it renders, then people will still have faith that even if I go to this institution, even if Dr. XYZ is not there,
Right,
I will still have a very good level of care.
Okay. Fine. Return to you.
So our next question is, how does a hospital maintain patient safety and quality of healthcare with doctors who might be new graduates who do not have that much experience, or with labor who might be unskilled?
It's a very simple thing, and that is training, training, training. You cannot underscore the importance of training staff continuously So therefore, what typically happens is, and in my experience, I have done it. You train a team of people who understand what is to be delivered, and when you train that team has to pass it down the line. And if they do that effectively under supervision, with the carrot and stick policy, that if you do good work, you're praised publicly, and if you have done something bad, then you are scolded privately. And that's very important.
Yeah. Yeah.
So therefore, if you do that, then in that case, the legacy of what has been put in the hospital continues, despite the people who have been the original trainers having departed from the organization.
Okay. So, but do doctor demand for their own marketing strategy? I mean,
See, everybody has a selfish motive.
yeah.
So people will say that, you market me and your hospital will do very well, and if I'm there in your hospital will succeed. I am not a very great taker on that. You market each individual equally. Oh yes, I mean, there will be exceptions to the rule. There will be certain people who may have a flair of speaking. There may be certain people who have a flair of interacting. They will interact more. But there are some people who are a little reticent.
Yeah.
Just because they're reticent, that doesn't mean that they're good in or not very good in their profession. So they should also be given an equal opportunity as far as the market forces are concerned. Now, if they feel that yes, they are exposing me, but it is my shortcoming that I'm not able to create a vibe for myself, then in that case, they don't mind if you promote others, but so long as the ripple effect is felt by them.
Okay. So, typical social media kind of promotion or a TV or a radio jingle for the doctor is okay these days.
It is something that is very well accepted, and I think there's nothing wrong with it.
Okay. Okay. Continue.
So probably one of the biggest pain points that we have seen now in recent times is workplace violence that can happen on doctors. So how does this typically happen, and what really are the ways to keep our doctors safe?
So the way is that please be transparent. We are all human. We are prone to make mistakes. So therefore, if there is an honest mistake, that should be explained to the patient in layman's language. Despite that, if the patients have a shriek of agony where they have lost a near and dear relative, then there has to be a team which gathers around the patient to help the patient in any way that they require. Maybe a concession with the billing, maybe a quick discharge, a quick release of the body, and things like that. Despite that, if things are going awry, then in that case it is number for number. If they are 10, the hospital should have at least 10 people there. If they are 20, the hospital should have 40. So therefore, everybody should come down in that particular area, because when you have force, facing force, then everybody has courage. So therefore, first thing first, be honest, surround them with people who are helpful, and failing which, force with force.
So, does this real, I mean, kind of the trend, does it really warrant to have bouncers at the entry exit of the hospital now to protect the internal staff from the menace outside?
Well, you must have security.
Yeah.
You must have a security process.
Okay.
But if you are going to have bouncers, then the indication is that you're ready for a fight. So just because you have bouncers doesn't mean the other people cannot bring people with bigger muscles.
Okay.
So where does the muscle battle end?
Yeah.
So therefore, instead of that, I think the first thing is a logical approach, be compassionate, be empathetic, and then force by force. If you raise your hand, I will raise my hand in double.
All right.
So therefore, I would defend myself to the fullest.
Absolutely.
So if you're talking in terms of a bouncer, that might also give a negative connotation.
Okay.
So people may bring other people who would be ready for a fight. So therefore, I think that we walk down, we speak to people,
Right.
we talk to them, we become empathetic, we are compassionate, we help them in every which way, and after that, call all the staff of the hospital down, and we all stand together. There is nothing as encouraging or courageous for a hospital to have its entire team support the organization.
Absolutely. So the following question, I mean, just kind of around this initial question, the role of clinical counseling in this particular kind of domain, will it really help to reduce such kind of chaos or say a reduction in the medical legal cases?
Let me tell you one thing is that if you have a situation which is going south,
Yeah.
then in that case, there is always a team approach. There are multiple doctors in this day and age who treat patients. Therefore, all of them should sit with the patients, their relatives, and answer their questions with knowledge as opposed to the patient who has just got information from the net. So, therefore, if you have a joint team approach, very recently we had a patient who was not doing well at all. So, we gathered a team of neurologists, intensivists, as well as general physicians who were managing the case, who sat with a group of relatives and explained everything to them. Now, here's the point: the patient expired, but contrary to what we expected was the patient actually gave a good report on a Google platform, so that we were well looked after. You can't always win the fort. We are but human. Life is given by the divinity. So therefore, if you have divine powers, well, cure everybody. But we don't have divine powers. So therefore, we explain to everybody.
Okay. So small segment of tumor board may really help. For
It's
all
not a tumor board.
Yeah.
A tumor board basically discusses cases
cases. Yeah.
and the modality of treatment and how you approach it. What I'm talking about is something completely different.
Okay.
It's a joint clinical approach
Okay.
to a patient who's going south. So therefore, suppose there's a diabetic patient who's got a neurological problem, who's got a nephrological problem, and is in congestive failure. So you will require an endocrinologist,
Right.
you will require a cardiologist, you will require a neurologist, and you will require an intensivist. All of them, all four, sit together and speak with the relatives
Okay.
on each domain. Now, the conversation is always started with the physician under who the patient has been admitted, and the rest of the crew then support the line of therapy and explain to the patient that we tried our best, but we couldn't win the fort.
Okay. And then the tangent to this circle will be financial counseling.
The financial counseling has to be done on a regular basis, and that has to be done on a daily basis, and that has to be done by the billing department.
Right.
So the next question is hospital and hospital administration a profitable venture, especially with major brands now entering the field?
Hospital is already a sunrise industry. But you see, because please try and understand the demand is enormous. We are 1.4 billion, and there is supply constraint. We can't run hospitals in the traditional manner that you have an administrative department and then you have your doctors and they come and treat patients, etc. Now, newer business models need to be adopted. Group practice is something that one would definitely look at. You would engage a company of doctors. So therefore, 5, 6, 7, 10 doctors form a company, and you engage that company. See, now what happens is that each and every member of that group will have to attract patients.
Yeah.
Now, there is always a leader of the company or the owner of the company, and we do revenue share models. So, obviously, these sort of business models in the future will pay rich dividends as opposed to a single doctor driven practice, because of the fact there's something called fatigue. And if you are going to be operating right from morning till midnight, and then you have an emergency at about 3 in the morning, you're at your worst. But if you have a group practice, somebody else is on call, he takes over, he manages everything. When you're fresh, you rejoin the team, and the results are automatically better. At the same time, you can take leave, and in that leave, you're fully paid. For example, you may get 2 weeks leave at summer, 2 weeks leave in winter, and you spend time with your family because you're not losing out on any money. So therefore, these are the emerging models, and some of the models are very well established.
So we are right, there is hardly a single bed for 1,000 patients. I mean, the statistics say for 1,000 patients, there's hardly a single bed available. And government recently announced that 10,000 MBBS seats will be soon kind of come into picture. So and all top end business tycoons are getting into kind of forayed into the healthcare industry. So is it really a profitable, say, at the fifth or seventh year of its operation? Or it may take time. It's a long association to have a break even in the hospital sector as a profitable venture.
See, it depends on what all you invest in. Now, your investment, as far as the land is concerned, the building is concerned, the MEP services are concerned, those are all, you just have to incur that. But when it comes to medical equipment, I think people should be a little cautious. And at the same time, it doesn't necessarily mean that you have to buy everything which is imported. You can also buy a very good, durable material and medical equipment which is made in India. So, therefore, if you understand that, look at patient comfort first, and then after that, look at your medical equipment which can give you correct delivery of, what I mean is the correct result and a high end result. Go for that. You don't have to all have international brands at every given time. It's really not necessary. There are some very eminent companies in Vapi who are making a lot of cardiac stents. They're making implants. They're making stents. They're making cardiac valves. So therefore, in that case, why not choose that? Now, if you do choose that, the results are equally good, and at the same time, you don't spend so much.
Right.
So therefore, your margins, the returns are also good. So therefore, their period of 5 years should be enough for you to cover any interest that you've taken as well as your depreciation. Now, a point over here. Most people feel that there is a notional cost as far as depreciation is concerned,
Right.
but it's not a notional cost, it's a real cost. Because if there is equipment A and you have recovered the entire money that you spent on the utility of equipment A, then in that case, when you have to replace equipment A, you have the money. You are not touching your savings. You don't have to take a bank loan to reinvest and buy. You have actually got enough money to cover your depreciation. The interest that you gather from your fixed deposits, which you make, should be able to cover the inflationary costs which occur year on year. So, if you are running a very strict, a sort of business model, I don't see why you should fail.
Okay. So cutting the corners at right angles is a key.
Don't cut corners. Don't cut corners. That's cheating. But
Okay.
financial pragmatism is something that one should follow.
Okay. Okay. So the next question, the pros and cons of the outsourced departments. Typically the housekeeping, the securities, the catering. What are the goods and kind of bad evils of that?
See, the line function and strategic function. Now, as far as line functions are concerned, how am I skilled in that?
Yes.
So, therefore, if I don't have skills in that, why should I want to do it? So, I will outsource it. But there are certain things that the person you outsource or the company that you outsource, say your security, as you said, catering, as you mentioned, they must comply with all statutes. So if they don't comply with all statutes, then the principal employer is responsible.
Yeah.
So that is something that you have to look after. The second thing is that the contract should be such that there's no question of their employees joining a union. If they indulge in unionization, then the company who you've outsourced this to is fully responsible.
Right.
So that goes for every outsourced agency. And should you pick up that there is murmurs of unionization, it is better to get rid of that company before the company does, is not able to manage their crew. Now, as far as strategic outsource is concerned, some people outsource areas which is a very high ticket investment, radiology, radiation oncology. So these are high ticket investments.
Yeah.
It's good to outsource it. It's very good to outsource it so that you understand that you have a partner and you develop business models with that partner. Now, this is very good. And the reason why I'm saying that this is very good is that at a certain time, you may feel that the business partner is earning more than what you are earning.
Yeah.
But that you should offset with the fact that in your contract, you need to mention a new change of equipment. Now, for example, if you have a 1.5 Tesla MRI and you want to buy a 3 Tesla MRI, then the cost is huge.
Yes.
The difference is huge. But the partner is paying. No skin off your teeth.
Right.
So therefore, those are the things, if you don't build in to the initial understanding, then in that case, you're going to land in trouble. But one thing is certain, you have to accept responsibility.
Yes.
If your partner fails, then it is your failure.
Right. Even the partner makes a folly, you are responsible.
You're responsible. So if the partner should not fail, and you will make every effort to see that the partner doesn't fail, then in that case, it's a very successful business model.
Right. We'll take a 2-minute break.
Yeah, just a follow-up question to this. So since you mentioned that a hospital should have like a sort of a clinical team such that we can sort of cater to patients particularly and sort of give them that care that they're deserving, is that not similar to some sort of a union or something like that, at least in its ideology?
No. Here you have a number of professionals who come together for a particular situation. Otherwise, they're independent. They're working on their own. They're treating patients on their own. But here, they come to a situation where the hospital sends for references to a particular person who's skilled at a particular field. Now, patients may have comorbidities. So if you have comorbidities, like for example, as the example that I gave, patient with diabetes, having cardiac problems, having neurological problems, cannot be managed by the intensivist. So therefore, the intensivist or the endocrinologist will require the cardiologist's help. But suppose the patient is sinking. Now what do you do? So therefore, the first point of contact is the intensivist. But the intensivist should bring with him or her the cardiologist, the endocrinologist, as well as other neurologist, and sit down and explain to the patients very clearly. The patient came with this condition, this is what happened, this is how the patient is going down, these are the things that we're doing, we're trying our best, but God willing, we succeed. But we're just giving you a heads up that things may go south.
Right. Awesome. So another just kind of link to this is pharmacy and pathology a good idea to outsource?
No, I don't think it's a good idea to outsource. I think in pharmacy, one should not outsource pharmacy at all, because it's an area where it's not a question of money anymore. It's a question about the quality of product that you get, and you're going to be you're completely dependent on a third party to give you something which you're going to use on a patient. So I think that part is not there, and the pathology is not a hugely cost intensive department as opposed to radiology or radiation oncology. So
Okay.
therefore, it's hardly a thing
Understood.
that I would outsource. I would never outsource it.
Okay. So is generic acceptable by you? Generic medicines.
Generic medicines are okay. There are companies which make generic and they make branded.
Correct.
So therefore, you can take the generic from the same company. There's a lot of hoo-ha about generic
Right,
and
Yes.
branded. But if you compare the cost, you will find there's hardly any difference between generic and branded. So therefore, you can write generics,
Yeah.
and we'll provide generics, but if you write branded, we'll provide branded. The cost difference is not humongous, no?
Okay. So the accreditation process, I mean the ISOs and NABH, does it really helps or it only kind of warrants only paperwork documentation? I mean my question is, suppose you have a multi-chain kind of chain of hospital where your service should be same at whichever outlet you go. Suppose you have a burger, you'll get the same service, same quality at the outlets of a particular food chain. Similarly, suppose Adi Arogyam has another counter outlets in the close vicinity, and the person goes there, he should get similar service experience there. Will accreditation be prudent there, or it is also okay for a single entity?
It is a must for a single entity. It's a must. Because let me give you an example from the armed forces.
Okay.
There is total standardization. So therefore, standardization of weapons, standardization of logistics, standardization of uniforms, standardization of speech, standardization of menus, everything is standardized. So therefore, that is because they have enormous processes. Standard operating procedures is a creation of the armed forces. So if you have standard operating procedures, then you will not have a sinusoidal sort of care, this thing. One day you're very good, next day you're very bad. So standardization is mandated. The ISO certification, the NABH accreditation is absolutely mandated. And when you have these, your organization starts responding in a standardized manner. Now, either you are consistently bad or you're consistently good. You can't be good, bad, good, bad. So, therefore, if you're consistently bad, you have to improve yourself. And if you're consistently good, you have to aim for a higher consistency. So, therefore, standardization as mandated and accreditation is mandated.
Okay. So the staff remains on tenterhooks all the time. They're always up the sleeve. Is that the benefit?
No, there is no staff being on tenterhooks. And why should anyone want to be on tenterhooks? I mean, I understand that there are those three stressful days which come, but you've got to prepare for it.
Yeah.
I mean, you can't just say that, okay, tomorrow we are going to be having an audit, so get ready. It's not that way. You have notice, you prepare for it. You prepare as you prepare for an exam. But the fact of the matter is that every class or every subject has a curriculum. So you have to study the curriculum. So therefore, the hospital staff also has to study its own curriculum.
Right.
Now then there is an exam. So that's your accreditation. So you appear for that exam. Not everybody is going to get star marks. Some people will get below par. That's where the NC comes.
Okay.
So therefore, what does it do? It only improves you.
Right.
So if it is improving you, then why are you not doing it?
So, but the repeat process makes it monotonous or nothing like that?
Repetition is monotony, and it does become monotonous. But the point is that there are certain things that when you start doing and looking at it continuously, you feel that you're doing everything right. But when you get a third eye to view it,
Yeah.
they will point out certain errors which you overlooked. Because it's not in your domain, it's not come into your field at all. It doesn't come into your field of vision because you're so used to seeing it. So therefore, a third eye is always necessary after a point in time. So periodically, you've got to have a third eye review.
Okay. Okay. Got it, sir. So now there are metas and AIs in the healthcare industry everywhere. It's omnipresent. Can AI help in the reduction of the patient discharge process? I always notice 4 hours, 6 hours, you need to wait for the TPA clearances, you need to get the doctor's reports, nurse's report on single page, and the file is prepared. Can this new technology help reduction in the time process?
Yeah, I think artificial intelligence is the way forward because there are a lot of things that the artificial intelligence can do, and it can streamline a lot of your processes. And there can also be artificial intelligence which is used to predict the outcome of disease. So therefore, if you have, for example, during COVID, we were not sure. Nobody knew how to treat a patient. Nobody knew what was the best regimen. Nobody knew what was going to be the outcome. So what we did was we approached Wipro and we said that, can you create a software which could give us a predictive value? So they asked us, well, what is going to be the endpoint? So the endpoint is always death. So he says, from death, work backwards. So they made a small software for us, and I don't know whether that's part and parcel of artificial intelligence, but they put certain criteria. And if you put those criteria and you fitted that criteria for the patient, then you could actually predict that is the outcome going to be difficult or the outcome is going to be good. And if it's going to be difficult, then you take extra precautions. So therefore, that sort of thing will possibly, be the future where the predictive value for diseases would be certainly of great help. Now, when your talk about discharge, the discharge is going to be actually what the consultant needs to, write. So therefore, if the consultant is able to sort of give a summary and the AI tool is able to decipher that and fully implement it on paper, then it will be very fast. But the fact of the matter is that the consultant has to sign it.
Right.
Now, if the consultant is not available,
Yeah.
and the consultant has to come back to sign that,
Correct.
he has to then give the authority to the RMO that, okay, I'm happy with this, you sign on my behalf. So therefore, those sort of things are still, question marks. So would the consultant say, okay, fine, you sign on my behalf, I'm quite happy with this, whatever you've sent me, you WhatsApp it to him or you send it on mail and they read it and they say, no, I'm quite okay, signed on my behalf. Now that was signed on my behalf at some particular point in time has to be countersigned by that consultant. So therefore, the resident doctor can sign on his behalf, but the consultant will have to countersign that file.
Right.
And that is the law.
Yes.
So therefore, if you don't do that, then in that case, that thing is not valid.
Okay. So even though AI is there, but reduction of 4 to 6 hours of discharge time is little tough journey.
No, why the journey becomes tough is you start gathering all the data at the end. So if you start saying that, okay, this patient is going to be discharged tomorrow, and you start preparing all the data from today,
Right.
then you can reduce the discharge time to say at least 1.5 to 2 hours.
Okay.
But that depends on insurance.
Right. Absolutely.
So the insurance has to give you the approval.
Yes.
So now if the insurance delays the approval,
Right.
generally it is always the hospital's fault. But the insurance rings up the patient and says, oh, we've cleared everything, when they haven't. So therefore, sometimes these sort of things happen and delays will happen. But if we unite as a force, or we have a middleware partner
Yeah.
who takes care of all of this,
Right.
then I'm sure we can reduce the time.
Right. And sir, how dependable is AI vis-a-vis doctors' hand-eye coordination or skills or judgment?
Too early to say. Far too early to say. But in time, one would come to know.
Yes.
So, speaking on the topic of insurances, how does a hospital make sure to maintain its cash flow when the recovery of money from insurance might take a very long time, or a patient can not be able to avail of the cash flow at that time?
We are blessed at the moment with the mix and match. The mix and match is that there are patients who, have they want to pay in cash themselves. They're self-paying, or what you call self-paying, and then there are patients who come with the insurance part of it. Now, the insurance also has a clause built in that if they settle your bills within 7 days, you have to give X% concession, which is fair. So if one agrees to that, you don't have to agree to it. But if you do agree to it, then I'm sure that the insurance approval time, if it is managed within about 7 days, the cash flows, are 7 days away. So therefore, it is manageable. But yes, you're right that some insurances take 45, 60 days for payment. That's a difficulty that is real, and I really have no clear-cut solution as to why, until and unless, like MSME,
Yes.
we also have the liberty of raising it to an ombudsman, who would then tell the insurance company that your registration may be cancelled.
Right.
And then you will get your money very fast. So if we can be included, healthcare can be included into that. I'm not saying as an MSME, but I'm saying as a in healthcare organization, if the insurance fails to pay within a stipulated period of time, then they may lose the license.
Okay. So if whatever reasons patient doesn't pay, as a hospital, what's the upper limit you can try?
Well, look, this is a evil which is practiced. People they come to you running, and they will say that I can afford anything. Please save my patient. But if the patient is no more for no fault of yours, then you will find a political leader landing up and making a big issue, etc., etc., etc.
Right.
But if the patient is not willing to pay, then you really have nothing very much apart from saying that, okay, the contract is incomplete. The contract is that I treat you, you pay me, and then it's over. But you've not paid me, so I've treated you. I may not have been successful, but then I will not give you your papers. That's the only thing that you can do. You can't hold the body. You cannot hold a death certificate. Or you can just hold their papers and investigations in case they want to claim anything from insurance. But then the law is very grey over here. It's a very nebulous area which needs to be addressed in all seriousness. It needs to be addressed, and I'm sure the government of Maharashtra would take leadership over here and try and get this thing sorted.
Okay. So is there any kind of sleek chance of rationalization in the tariff structure? I mean, suppose there is a small surgery, hydrocele or a cholecystectomy. Can it be kind of brought down to a particular threshold across all the hospitals? I mean, it's a simple example. You get a Padir Makhanwala 250 rupees or 2000 rupees. Likewise, I understand we offer services, hospital offers services, but we can apply some kind of rationalization in the tariff or ticket size. irrespective of how aesthetic the hospital is.
If
Or
you go
yeah,
to the Taj Mahal Hotel and you ask for a Pepsi,
yeah, that's what's
there will be a big hole in your pocket. But if you walk down the road
yeah,
to a cafe,
yeah,
an Irani cafe, and ask for the same Pepsi,
yeah.
there's no hole in your
No,
pocket. I
yes,
hope that answers your question.
yeah,
Because in Mumbai itself, the real estate value is different in different areas.
right.
So therefore, just to say there's going to be a cost rationalization, it's a lovely term to use. But then in that case, the hotel must also offer the rationalized cost, which they don't. So therefore, I do not think that this is correct.
Okay.
And if the market holds the price that I am charging, so why should I not charge top dollar? Why should I not, have something which the hotel industry is doing? Here you say hospitality and healthcare should be alike, etc., etc. There should be a whole lot of hospitality, etc., etc. And then what happens in a five-star hotel? There you're willing to pay the bill. But here, no. I think this is double standards, and I just don't think that this is right.
Okay.
So therefore, if Taj says that and the same price as the other guy,
Yeah.
I'm also going to say same price as whatever you say.
Okay. Okay. Noted.
So speaking of this thing about prices, how does a hospital maintain the transparency in the billing procedures? Because a patient, first of all, doesn't particularly know all the medical terms. Patient might not be conscious while they are in the operating room or the ICU. How do you maintain transparency in everything that you bill towards the patient?
It's all itemized billing. It's all itemized billing, and I can't predict what I'm going to be using in the operation theater or I'm going to be using in the cath lab or anything like that. So therefore, we make all the bill is completely itemized, and we explain to the patient that this was used, this was used, this was used, this was used. Now, if the patient says that, how do I know that this was used? Well, I mean, how do you do a procedure without using certain things? And say by mistake, if a doctor or a nurse drops a syringe, what are you going to do? Pick that syringe up and use the same thing? No, you open another one. Isn't that an honest mistake?
Yes.
So while you're handing me an instrument and I'm looking at the machine and you don't slap it on my hand, then in that case I lose my grip on the thing which you've not placed properly. It falls. So do pick it up. So now let's have, for example, an implant. You're doing a hip implant, and the hip implant falls down. And then what happens? So there you're going to blame the processes. You're going to blame this. You're going to blame that, etc. But in the road there is no accident. So therefore, there are going to be charges, and you have to take me at face value. Now, for a simple hernia, if I'm going to be charging a huge amount of money, then I'm pillaging.
Yeah.
But if I charge, everybody does window shopping. So therefore, when you do a window shopping and my price is 10 rupees more, as an example, 10 rupees more than somebody else's, then I don't. What's the big deal? If you don't want to come to my hospital, then don't come to my hospital. But I'm going to be charging this because I think that is my cost, and I have to make a certain amount of profit. I don't want to profiteer, but I want to make profit.
So I think, just speaking on a ideological level for a doctor, because from what I understand, the role of a doctor versus the role of a hospital administrator is a bit different. The role of a doctor is to heal the patients, whereas the role of the hospital admin is to make sure that the hospital can be set up, can be run, you can pay your doctors. So what do you think personally, as a doctor as well as an administrator? Where is like the balance? Like where is the idea of, I want to treat this patient, but I also have to make sure I'm able to sort of end the day?
See, a doctor heals the patient, that is right, and the administrator's first job is to provide the environment in which he can heal the patient. So therefore, if you provide the right kind of environment for him to heal the patient, then in that case, it works very well, because then the doctor has huge respect for the administration. But if you say that, no, it's your job to do this, and my job is to see that you're doing everything properly and the money that comes in, that's where the conflict of interest comes in. Then the doctor says that if the hospital is only interested in my skill to earn something out of it, then in that case we are working divergently. If you want to converge, then you create that infrastructure in such a manner that they can render treatment well, effectively, and there's going to be a cost, and you have to pay me for my cost. I have to run the entire infrastructure. I have to see for the sterility. I have to see for the cleanliness. I have to buy the equipments. I have to upgrade everything. There's an AMC cost. There's a CMC cost. There's a staff cost. There's an electricity cost. So you have to share something. You're my partner.
Yes.
So you can't come to my shop without any skin in the game.
Correct.
So if you don't have any skin in the game, then you are not the right partner. But if you have skin in the game, then in that case makes a huge amount of sense.
Okay.
And then in that case you can run a very successful hospital.
So one question from the biomedical point of view. Having robots and navigation system and all new technology, high ticket, high modality equipment is really necessary at the moment, or we can stagger it, or you can more depend on the doctor's skill and judgment?
See, I'll tell you one thing. Technology is changing and there are new modalities of therapy which are coming in. And some of the therapies have to necessarily mandate the fact that you have very high-end equipment. But where is the bulk? The bulk is in the secondary level of care. So there has to be certain amount of sophistication. You have to have sophistication. You have to march with the times, but never go with me too. You have it, so do I. Then in that case it makes no sense.
Okay.
But if you're thinking in terms of new therapeutic modalities, they will demand certain amount of advanced equipment and sophisticated equipment for sure.
Okay. So it shouldn't be a marketing gimmick per se. I mean,
Then it
it's
becomes
a
me too.
needless types. Okay. Okay. Last question by you.
So I think one of the last questions is, so I am a healthcare architect, which means, and Hosmac is a healthcare architecture company. For instance, architects, when we learn in school, we don't particularly learn about hospitals and services or MEP or anything like that. So for us, when we come to such a field, it's a very bright and new thing for us to, first of all, understand all the terminologies, understand how to talk to doctors, understand how to talk to administrators, because hospitals are, along with airports, they are the most complex buildings to sort of build as well as maintain, because they have to run 24/7. So to ask to a doctor, what would your sort of main points be regarding a hospital, and in terms also of treatment, but also in terms of architecture and the aesthetics of how a hospital is and how it functions?
See, I think the most important thing an architect should do is ensure that the functionality of the hospital or the building that you create is met. So, what is that function? That has to be clearly understood by the architect from the people who are going to set up the hospital. Now, if they themselves give you, a little bit of a befuddled explanation, then your functionality in the hospital is going to be poor. So, therefore, clarity of thought has to be there. And then after that, they have to be very clear about the bed and space. Okay, so therefore, that is where it is key. It also, the brief to the architect should be the design flow of the patient. If at conceptual level I cannot give you how my patients are going to flow in the hospital, then your architect, no matter how good you are, you're going to create a sort of place where it is so difficult for the patient to flow in a smooth manner. So like you enter, you do registration, you go to the OPD, you go to your diagnostics, you go to your pharmacy, and then you leave the hospital. A very good concept. But you go to registration, and after that registration, then you have to walk across somewhere else for a diagnostic, and then you come back to the other area for some other this thing, and then you go back again, etc. Now look at the flow. So if everything is linear, then that works. And also, I think in the architectural schools, I'm sure they also explain various forms of architecture. The planning should be such that the patient or the flow is very limited amongst floors, and where the residencies are there is hardly any crowd. So therefore, that's also from the security point of view, from the cleanliness point of view, from infection control point of view. All these sort of things help. So therefore, I think the brief which is given to an architect should be crystal clear. If that happens, then in that case, the architect will definitely create a good infrastructure.
So, but eventually, the aesthetics of the hospital or having a high-end equipment, does it really beef up the patient billing?
High-end equipment, you are talking in terms
Like
of aesthetics, and then after that, high-end
yeah,
equipment.
both together.
Aesthetics are all important.
Okay.
If you have a good, looking infrastructure,
Yeah.
there is a natural tendency to go towards it.
Yeah.
So therefore, a very large ambience for, it's very welcoming.
Yeah.
In some cases, it might become intimidating.
Right.
So therefore, you got to work out the difference between intimidation and
Yes.
welcoming.
Right.
And then after that, if there is enough spit and polish, you don't have to have marble and granite everywhere. It should be neat. It should be clean. There should be enough natural light. That's something that like daylight harvesting and things like that. You must have these theories in place, and the organization must invest in daylight harvesting, so that the type of glass that you have is double jacketed with hermetically sealed windows and things like that. So while you get sunlight, you don't spend on energy. So therefore, there are so many things that you have to look at, and this is important. Surely, natural light gives you a terrific feeling when you enter a place, rather than electric lights. So therefore, those sort of things are very important. And at the same time, if you have equipment which you can say that, yes, I can do any test with this sort of equipment, then in that case, the patients feel also very comfortable. Or I have to send this outside. Oh, you go outside and get that treated and come back over here. So I might as well go outside and get treated elsewhere.
Right.
So therefore, yes, there's no escaping the fact that you need good aesthetics and you need good equipment. But does it have to be the world's best? Certainly not.
Okay. And so the last, word of yours or thought on the role of a consultancy firm like Hosmac in the planning, designing of the newly, new hospitals.
I've dealt with Hosmac.
Yeah.
I know Hosmac's strength. It's enormous. So therefore, the role is great. But again, as I say that, you will not be able to design if my thought is not correct. If I am confused about what I want, then ultimately you will confuse me in your design.
Okay.
So it has to be extremely clear that this is what I want and this is how I want it. And then an architectural firm like Hosmac will be able to deliver the goods in very good measure.
Okay.
But if I tell you one thing today and one thing tomorrow,
Yes,
and
absolutely.
change this door from here to there, I'm just saying that in light of vain.
Right.
But if what I'm trying to get across is that if my thought process is not clear, then the architect's thought process is going to be completely befuddled. So no matter how experienced Hosmac is, if I confuse you, uh, you will land up with a
Yes,
disaster.
yes.
So I think, and if I don't confuse you, then I know that a company like Hosmac will deliver.
Okay,
So I don't have to look back.
okay. So would you like to recommend Hosmac to all the new players in the industry?
Marketing at the end of it. So therefore, Shantanu Thate started with a podcast, but it was marketing at the end of it. See, I have always recommended Hosmac, and in my various avatars, I have always recommended Hosmac, and I have very warm relationship with people at Hosmac who I've known, for the past 25 years. So therefore, I don't think the instant recall is always Hosmac.
Thank you so much.
You're very
think
welcome.
It was very nice to have like this nice discussion on what the pain points can be
Thank
on
you.
the
Thank
hospital
you.
administration.
Thank you. Thank you.
Our privilege, sir. Nice talking to you.
Thank you.
Thank you so
Thank you.
much. Thank you.
Thank you. Thank you. Thank you.